welcome to our kidney transplant education. What we're going to go over for about the next hour or so is the introduction to transplant evaluation candidate education. So there's a lot of information that will be presented, and a lot of it is to assess if transplant is the right option for you. As you can see on the screen, this is our team here. It's a multidisciplinary team, all kinds it takes to make sure that transplant is the best option, and that way we can keep you healthy all the way till the end. My name is Allison. I am one of the transplant coordinators. You may see a couple of us throughout your journey here with ChristianaCare Kidney Transplant, but our ultimate goal is to get you to that end goal of getting a kidney, so we're all here for that. So at ChristianaCare, with any interaction you may have with our facility, these are kind of the motto we abide by: for the love of health. We serve our neighbors as respectful, expert, caring partners in their health. And we do this by creating innovative, effective, affordable systems of care that our neighbors value. So what to expect in this next hour. And also as part of the transplant evaluation, these are kind of all the components that we'll take a look at to make sure that this is the best option for you personally. So we'll take a look at any available medical records. Our clinical members of our team will take a look at them. Anything that you've had in the past, anything coming up, we will review all that so we can make sure we have a comprehensive view on your medical history. As you're attending right now, the virtual education session, which contains information about kidney transplantation, associated risk, and the evaluation process. You will also have individual telehealth sessions or in person with some of our other providers. You will meet with our transplant social worker, our financial counselor, our registered dietitian, transplant pharmacist, and then in person you will eventually meet our transplant nephrologist, our transplant surgeon, one of the transplant coordinators, and also eventually get some evaluation lab work. So there are two main objectives that brought you here today. So the first one is to see if kidney transplant is right for you by learning about the process, requirements, and risk, and also to meet your transplant coordinator. So you will meet other members of our multidisciplinary team through either telehealth or in person, but it's important to keep in mind that this initial evaluation visit does not automatically place you on the waiting list. So there is a process involved to make sure that this is the safest and best option for you. All right, hopefully it's still fresh in your mind, but this is something just to reiterate. Does an evaluation guarantee you a place on the waiting list? And the answer is no. What you have to do is the workup that we're going to take a look and see what you need by looking at your past medical records and kind of getting to know you a little bit better and determine if evaluation and kidney transplant is the right thing. Once we get through that, we work through the evaluation, all the testing and preoperative pause. So as we just touched on, does an evaluation guarantee you a place on the waiting list? Hopefully your answer is no with that. There is a process involved. That's why it's evaluation and a workup to determine if kidney transplant is the right option for you. Once we go through that process and as a team we make a decision in collaboration with you, and then we can place you on that waiting list if kidney transplant is going to be the best option. So now we're going to meet our members of the team. So these are various people you'll meet throughout your care with us. This first slide shows the transplant nurse coordinators. So we have Stacy, Claire, myself, Allison, and Jennifer. So what we do is we guide you through the testing. As you're completing that, we share information about that with our team so that way we can see if there's any additional follow-up that may be needed or if we need to refer you to any other providers. We'll collaborate with your healthcare providers regarding your testing. It's important that whoever you see now, we want to continue them in the care and any follow-up that may be needed. We're your main resource for support and answers, so there's going to be a lot of questions, a lot of gray areas that you may not be sure about. That's what we're here for. Anytime our team makes a decision, we do meet weekly on Wednesdays as a whole team and take a look at different cases, different patients that may need to be that we may need to take a little further look at. So any decisions that are made by our team during those meetings, we will communicate that with you. And then we're your point person while you wait for transplant. So we'll have a great relationship, work with you to get you to that end goal of transplant is the right option. These are our transplant nephrologists. So we have Dr. Burke, who is our medical director. We have Dr. Chang and Dr. Jilly Bear. So you will see one of them in an office visit at a later time. They are trained as medical kidney doctors or nephrologists. So you already have a nephrologist that you see outside of here who referred you to us today. But these are our specific nephrologists to kidney transplant. They help address any blood pressure, electrolytes, and any other non-surgical issues related to transplant. They can help coordinate medical issues that may impact the kidney transplant. And then once a transplant is achieved, they manage the long-term immunosuppressive medications that our post-transplant patients need, because we want to keep that kidney going for as long as possible, especially when you work so hard to get one. All right, these are our transplant surgeons. We have Dr. Rolls, who is our chief. Dr. Swanson, every once in a while he did retire, so we have a new transplant surgeon coming on board soon, but every once in a while he will help. So what the transplant surgeon does, they will also see you at an in-office appointment, so that way they can assess you. They actually perform the transplant surgery itself. So they will help determine if a patient is suitable for surgery by doing different testing and imaging. And they also, once we're in the post-transplant phase, they manage the anti-rejection medications at that point. This is Eileen. She's our transplant social worker. She'll most likely have a telehealth consult with you, so on the iPad. And she will also have your support person with you as well. So directs you to resources for any health and family issues that you may need. If there's any recovery, rehabilitation resources, she's your point person for that. She assists with insurance or medication problems. She leads various support groups for patients throughout the year, so it's a good thing. With Zoom, you'll get information sent to your email. Hopefully we have that on file. If not, be sure to give it to us so we can send you out information on these groups. They're great for learning more information, just feeling supported. And then if necessary, she can make referrals to any psychiatric or other counselors as needed for your individual situation. Barb is our financial coordinator. She will also contact you via telehealth or on the phone. She takes a look at your insurance. So it's important if you change your job, if you're working, if your insurance changes, if you move, anything like that, that you let Barb know. So she's your contact person for any insurance changes. She'll take a look at what you have and check for any benefits, make sure that it's appropriate for transplant-related medications post-transplant. If you have any questions, she's great for explaining Medicare, Medicaid, Delaware chronic renal. She is a good source for information on that. So be sure to give her a call if anything changes during your time with us. Molly is our transplant dietitian. She also will have an individual telehealth consult with you. So she assesses your current nutritional status and compliance. So she'll take a look at your lab work, kind of what your current diet consists of, and kind of give you some suggestions on how we can make that better for you, for your health. She can provide individualized counseling based on the individual's needs, such as weight loss or weight gain to meet our BMI standards, increasing protein to improve albumin, any pre-dialysis diet education, modified diet for depending on your lab work to improve those lab values, especially with potassium or phosphorus, and then any questions or any kind of just in general food questions you may have. And then post-transplant, she assists with those diet changes as well, since there'll be a different needs at that point. All right, this is Nadia. She's our transplant pharmacist. You also have an individual telehealth consult with her. She records and evaluates your allergies and also reviews your medications. And it's important to let her know prescription and non-prescription. So any herbal supplements, anything over the counter, it's important to let her know those medication types. She can explain the differences between current and post-transplant medications and what her role as the pharmacist is in your care after transplant. Any medication-related questions, Nadia would be your point person. And it's very important that we take care of the whole you, just not the medical side of you. We want to make sure we take care of any spiritual needs that you may have if this is important to you. So we do offer spiritual or pastoral services during any phase of care here at Kidney Transplant. It's a during evaluation. They will happen over the phone. They can be there while you're waiting on the list. We can contact them via the phone, any hospital admissions, and post-transplant. It's important if this is something that's important to you. Their number for contact is 302-733-1280, or we'll be happy to help you with that if you would like. So good number to note if this is something that's important to you in your health care. Your current nephrologist is also an important member of this team, so while you're waiting on the list, you will still be cared for by your current nephrologist, whoever you saw to refer you here today. They will continue to handle dialysis if that's applicable to you, any hospital admissions. But immediately after kidney transplant, your care kind of transitions to be managed by our team due to the sensitive nature of what we're trying to keep that kidney good and not be rejected. So after about a year or so of that, your care will be shared by both the transplant team and then your current nephrologist and your primary care doctor. We bring them back into the picture to help transition that care over. Transplant cardiologists, they're another member of our team. So you may have a cardiologist that you already see, and that's awesome. We want you to continue to see that provider. But we also bring in a transplant cardiologist who there's a specific group of them. So they have to see you prior to being able to list you to ensure that you're an appropriate candidate for transplant surgery. And then while you're on the waiting list, you will continue to see them annually or more frequently depending on what's discussed. And like I mentioned, you'll see them in addition to your own cardiologist if you already have one. And last but not least, the most important member of our team is you. We need you to be just as involved in your care as we are. We want to get you to that ultimate goal of kidney transplant if it's the safest thing for you, but we need you to be very active involved in your care. So it's important that you contact your coordinator with any changes in your phone numbers, your address, your dialysis centers, any changes in your health. We want to know about that. Please let us know or have your support person reach out to us. As you're seeing some of the other providers that we may have you see, or while you're seeing your own providers, we ask that you have those test results sent to us. And if they need to send it by fax, this is a good number to know, 302-623-3825. So we're going to be hand in hand with each other throughout the process, and we just need you to be just as on board and involved in your care as we are, because we want to get you to that ultimate goal. So that's our team. So we're going to get a little bit more into the education part of it. So for kidney failure, there are two treatment options. One is kidney transplant, which is preferred for those that are medically eligible. When we look at kidney transplant, we have living donors, which we can usually get a transplant completed in less than 1 year. And then deceased donors. The wait list on this can vary depending on your blood type, but we're looking at a 5 to 10 year wait. And there is a 60% waitlist mortality in 5 years. So that's why we want living donors. We'll talk a little bit more about that later, but it's the ideal way because we can get you transplant in less than 1 year if everything pans out. Besides kidney transplant, dialysis is another option, so it's a bridge to transplant for those medically eligible. There are two types. There's hemodialysis, which you have a catheter or a fistula that's connected to a machine that filters and acts like your kidney, since the kidney can't do that job as fully as a normal kidney. And then there's peritoneal dialysis, which is delivered through a tube that's surgically inserted into your abdomen, and it also filters different solutants out for your kidney. So patient survival is better if you are transplant than staying on dialysis. In order to be eligible for transplant, you either need to be on dialysis, that can be hemodialysis or peritoneal dialysis, or if you're not on dialysis, we look for a kidney function, what we call an eGFR, estimated glomerular filtration rate. So this is on the lab work that you get done from your nephrologist, but that has to be at or below 20%. Some people, as great as transplant is not the best and safest option for them. So we're going to go over these next couple slides about who transplant may not be an option for. So if you have severe heart disease without any possibility of intervention, if you cannot get stented or have medications to help with that medically, if your heart's not good, it's going to impact your kidney, so transplant's not going to be the best option at this time. Any other organ failure requiring transplant, so if you need a kidney and a pancreas or a kidney and a liver, multiple organs, we're going to refer you to another transplant program that can handle both of those. Here at ChristianaCare, we only do kidneys at this time, so we'll find a program and work with you to get you referred to that program. Anyone with irreversible essential organ failure, so if you have another organ that's failing that cannot be reversed or taken care of. Any current malignancy or cancer. So post-transplant, we give you medications that kind of wipe out your immune system because we want your body to accept that new kidney. And at that point you're very vulnerable. Any cancers can kind of ramp up at that time. So if you have a current cancer or malignancy, we want you to get that treated and wait the time needed post in order to be the best candidate for transplant. Any active infections, HIV infection or AIDS, this is, again, we're wiping out your immune system post-transplant, so these kind of things can put you at risk. Multiple medical problems making surgery unsafe. Ultimately, our goal is to make sure you're safe and we're doing the safest thing for you. So any of those other multiple medical problems, or what we call comorbidities, that would make you unsafe for surgery, we will not proceed with transplant. Age greater than 75. So we do have some age limits that we take a look at. These are kind of a soft stop, but age 75, we're going to kind of have a different discussion on living donation. Significant blood vessel disease. This is a blood vessel surgery, so we need your arteries and your veins to be good. If those are diseased, severely diseased, and it can't be corrected, transplant surgery is not going to be the right option. Those that are unable to care for themselves or do not have a support person, you're going to need a lot of support throughout this process. There's going to be appointments that you need to be taken to, especially post-transplant, making sure you have all your medications and you're taking them appropriately. So it's a very important piece of the puzzle here. BMI greater than 38. So BMI is a calculation that we do with your height and your weight. So if this number is greater than 38, we may suggest some kind of weight loss, and Molly will work with you to achieve that to see what's needed for that. And then patients without means to financially afford post-transplant medications. There are a lot of medications involved in that phase of this care. So that's why it's important to connect with Barb and make sure you keep us up to date with any changes with that. Patients with active illegal drug use. So drug use in general is just not a good thing. So transplant's not going to be the right option for you if that's your current status and you're not willing to change or go through the treatment options. Any patients with psychosocial contraindications. So we would work with Eileen to get you the support that you need to get you through to make sure that all your psychosocial needs are taken care of. Patients with cancers that have been treated. So there will be a wait time depending on what kind of cancer and what stage it was that we will take a look at to see if that time has been met, or we need you to wait a little bit longer to make sure that cancer has completely resolved and been treated. Patients with recurrent infections, we want to kind of understand why are these happening, because we don't want these to pop up post-transplant when you're most vulnerable. So we would work with your other providers to have you go through the process to get those worked up and see what we can do to take care of that. Tobacco abuse, smoking, chewing, vaping. If this applies to you today, we want today to be the last day that you have any tobacco use at all. Tobacco use, smoking, that nicotine, it can impact your blood vessels, which makes surgery a lot more difficult and not the safest option. So if tobacco is something that you smoke, chew, or vape, we want today to be the last day. And there are plenty of resources out there we're happy to help you with. Untreated sleep apnea, or if you already have sleep apnea and you have a CPAP machine or BiPAP machine if you're non-compliant. So again, these are all things that can be reversed that we can work on. With sleep apnea, if you've ever been told that you snore or you stop breathing at night, let us know because we want to get this treated. We have resources with our sleep study lab that we can refer you to have this take a look at. So when you stop breathing or you're snoring like that, you have this sleep apnea, your oxygen levels are impacted and they drop. That impacts your heart, which impacts your kidneys. So this is something there are many solutions to with CPAP or BiPAP, and there's a lot of more coming in the medical field of options for sleep apnea. But we want you to get worked up to make sure that this isn't something we need to address, or if it is, that we get it taken care of. And if you already wear BiPAP or CPAP, we want you to be compliant with it. We'll take a look at compliance reports and make sure you're wearing it and getting the most benefit out of what that treatment has to offer. Vaccination. So COVID-19 vaccine, I know there's been a lot of talk about it. So it's important that you are protected, that you have the vaccination according to the CDC guidelines and those put forth by our ChristianaCare kidney transplant program. So this is something the providers will discuss more specifically for your situation, but something that we are highly advising at this time. So you may think to yourself, why do I have to have all this testing done? Top answer, ensure your safety. That is our goal everyone on this team, our goal is your safety. That's what we keep in mind with every decision and action that we have. So we want to protect you from possible post-transplant medications, those side effects that can pop up. We want to make sure your blood vessels are healthy enough for transplant surgery. So we need that testing involved so we can make the most educated and safest decision for you. So some of the testing, routine testing that you may need to get listed. Again, this is every situation is a little different because some people may already have this testing recently and some people may need additional testing, but this is in general what you'll need to be listed. So cardiac testing, we will defer to our transplant cardiologist that you see to see what you may need. So they may order an echocardiogram, which is kind of that ultrasound on your chest of your heart. They may order a stress test. Sometimes they order both. It all depends on the individual. So the cardiac testing will help us to decrease risk of adverse events during or after transplant. Again, we want to make sure your heart is healthy enough for the surgery and ensure your safety. Evaluation blood work, it can be a lot of blood work up front, and there may be more blood work required depending on kind of your medical history. So this helps us decrease the risk of adverse events during or after transplant as well, and gives us a look at, we do viral testing, we take a look at everything to make sure there's nothing we have to treat before we can proceed with putting you on that wait list. A chest x-ray, that's the picture you see on the screen right now, picture of a chest x-ray, and CT scan or a CAT scan of your abdomen and pelvis, sometimes your chest. Sometimes we also do ultrasounds of your abdomen or your legs. These are all things that we're going to take a look at to make sure there's no cancers hiding, anything in your blood work that we may need to have addressed by your primary care doctor or other providers. All things to make sure you're safe. Your general healthcare maintenance. These are things that everyone should be doing regardless if they're being worked up for kidney transplant or not. So your primary care physician can help coordinate a lot of this testing to make sure it's current if it's not already. So for women, we want you to have a mammogram if you're over the age of 40, or for your individual situation if you have to have that sooner. Also a GYN or PAP exam for women of all ages. These again are testing that we do, general healthcare testing to make sure there's no cancers that are hiding or anything that we need to take a look at and address further. A colonoscopy for everyone over 50. You may have heard this may be changing to 45. We're still waiting for some other things to catch up, but the American Cancer Society has suggested 45, especially if you have a family history of colon cancer. And Cologuard is not appropriate. We do request a colonoscopy so that way you can actually take a look and see what's maybe hiding in there if everything checks out just fine. We'll have you see a dental provider if you don't already routinely see a dentist, and provide dental clearance to rule out any infections or cancers in your mouth. Even if you have dentures, sometimes your gums and under your tongue can be some hiding spots for this, so we want dental clearance for that. We do ask that these general healthcare maintenance items be completed within 3 months of evaluation. We understand with COVID, sometimes a little harder to get into these routine providers as it was before, but we'll work with you to get that accomplished. So testing must be complete. So you will not be approved for transplant or added to the national wait list until all your testing is completed that has been ordered and those results have been received and reviewed by our team. So it's important that you communicate with us. Let us know as you're getting things done. If it's done at a ChristianaCare facility, we can look it up real quickly. If not, we'll have to request those records if they didn't already send them over. So we have to have all that, anything that we ask you to complete. We need that before we can consider you for being on the wait list. So the reason why we want to get that done sooner than later, as soon as we can, is depending on your blood type. When you're waiting for a deceased donor, wait time is a key factor. So the average waiting time is 5 to 10 years in our region. If approved for transplant, we will notify and get you registered on the national wait list. So there's 2 lists that we talk to. We have UNOS, or United Network for Organ Sharing. They are a federal agency that manages the process and information on all potential listed recipients throughout the United States. And then there are OPOs, or Organ Procurement Organizations. So here in our region, we use Gift of Life. That is our local organization. They're based out of Philadelphia. They manage organ offers both locally, which is a 250 nautical mile radius, which we'll get into on the next slide, and also nationally. So they notify the transplant centers, such as ourselves, when a deceased donor organ becomes available. So what we were just talking about, that 250 nautical mile radius, this is what we're talking about. So if you look at this map, this red dot is ChristianaCare. That's our transplant center. These other larger blue dots are other transplant centers in our region. These small dots are potential hospitals or centers that we could receive kidneys from. So if you take us at ChristianaCare, this is our 250 nautical mile radius for our region that we could receive kidneys from locally. So there is, you may have heard of multi-listing. So what that means is that some people, they'll list, say, at ChristianaCare, and then also list down in Virginia or down in Maryland to get a different radius involved for different offers. So there are some advantages and disadvantages of that we want to talk about. So advantages could be including increasing your chances of being matched with a deceased organ donor. It could also potentially decrease your wait time for a deceased donor. But you have to keep in mind that you must travel to the outside center if you go to another center, and that's where you're offered a kidney for all your transplantation and all your post-operative care. There can be an increased risk of delayed graft function, or what we call a sleepy kidney, as the distance of the donor to our center increases. So there is little benefit in multi-listing at centers that are close by, as you will most likely receive the same kidney offer. So if you were here at Christiana and you went right here to New Jersey or Pennsylvania, you're going to get relatively those same offers that you would get by a ChristianaCare. You just may have to drive farther for the transplant and for the post-operative care. So important things to keep in mind. So why is there a wait list? We wish there wasn't. We wish we could give everyone a kidney as soon as they need it, but unfortunately that's not the situation we have right now. So these numbers are increasing. They are from 2016, but approximately 750,000 people in the United States have end-stage renal disease. Greater than 100,000 people are on the kidney transplant waiting list, and this increases every day, unfortunately. We look about greater than 17,000 kidney transplants that are performed each year, and about 1/3 of them are from living donors, which is the preferred way to go, and the other 2/3 are from deceased donors. So get through the evaluation process, everything's good, we get you on that wait list. While you're on the wait list, there may be two different statuses that you may be between. Our ultimate goal and your goal is to be listed status 1 or active. This means all your testing is complete and up to date, and you're ready for transplant and can be offered a deceased donor kidney at any time. But we also understand sometimes things happen, especially with COVID being as rampant as it is and just life in general. The other status is listed status 7 or inactive. So you'll continue to gain time on the wait list, but you will not be called for a deceased donor organ offer. So some reasons you may be listed status 7 include a change in your functional status. If you had a cardiac cath and had to have a heart stent placed, because of the medications, you'll have to wait 1 year. Or anything that temporarily makes you not a candidate for transplant. If you have COVID or in the hospital, anything like that, you may go to an inactive status, so you're still gaining time until you get through whatever that is and get healthy again to be back to active. So types of donors, there's living donors and deceased donors. Both are a true gift. So we're going to talk a little bit about living donors now. So living donor transplants, the living donor can be related to you or unrelated to you. They also have their own criteria and workup that they have to do in order to be determined eligible for donation. They must be between the ages of 18 and 65. They have to be healthy. We have to make sure they're going to be okay with one kidney if they donate their other one. They must be willing and want to give. You cannot pay someone or coerce someone to give you a kidney. This has to be something they do on their own free will and they want to do it. And you have to have compatible blood types to donate directly to you. Some advantages for living donation: you do not have to wait years and years at risk on that waiting list. So like we talked about before, we can usually, if everything pans out, get you transplanted in less than a year. There's a shorter time between kidney removal and transplantation, so these procedures are planned. It's not like you're getting a phone call in the middle of the night for what the deceased donor kidney. These are all mapped out and planned. So there's shorter time for that from when the kidney is removed from the donor to transplant it to you, the recipient. So with that, that kidney spends minimal time on ice waiting to be transplanted. So we don't see that delayed graft function or sleepy kidney that we do with the deceased kidneys. There's a planned surgery, and we often see better outcomes when we go this route. So the living donor program has a different nurse coordinator. So they work with the living donors to ensure they're healthy enough to donate. They're going to get lots of lab work done as well and additional testing that they have to do. We want to make sure that they're blood and tissue type compatible. So that's an important part in order for them to donate to you directly. Living donor transplants can be challenging, but they can also be very fulfilling. So the timing of the donation is determined by the donor. So for example, if the donor is a teacher and they don't want to miss time off of school, they may opt to donate in end of June, so that way they're off the summer and it doesn't impact their work. So that is determined by the donor. But please keep in mind that as with everything, we want to keep everyone's health information and private information confidential, so we cannot share information about the donor with you, such as why they were turned down if they were turned down, or why they decided not to proceed further with the donation. If you have a living donor, someone's mentioned in the past or recently that they would be interested in donating a kidney to you, they can start by doing that general healthcare maintenance that we are going to have you do. Make sure that's up to date. So they can talk to their primary care provider and make sure their age-appropriate testing is current. So annual physical, a mammogram for women over 40, a GYN exam for all women, colonoscopy, and make sure their vaccinations are up to date. So they can be doing this in conjunction with you while you're working through your testing as well. I'm not sure how many people have seen this, but this is a little chart of kind of your blood type and what kind of blood types you can receive. So over here, we have the recipient blood type. We have O, A, B, and AB. On the other side, we have the donor blood type. So if you are a type O blood, you can receive only type O blood or kidneys for this example. If you're a type A, you can only receive A or O. Type B can only receive B or O, and AB recipients can receive from everyone. They can get AB, O, and AB blood and kidneys. In the kidney world, we do not look at that positive or negative as they do with blood. So we look at that letter, if it's O, A, B, or AB. So don't get discouraged if you have someone who's interested in living donation and they are not the same blood type or a compatible blood type with you, there is another option. So we have the paired kidney donation program. So this is something that we work with National Kidney Registry on. So it's an alternative way of receiving a kidney from a living donor when you and your donor are not a match. So if both parties agree, you and the donor, you're entered into a paired donation program. If you take a little look at this picture, so we have this first pair. We have the donor and the recipient. So this would be you and your donor. You're not compatible, but we put you in this program and we find another pair that they're not compatible, but if we did a switch, each recipient would receive a compatible kidney from the donor. So it's just like a swap, just as it's a simpler way to put it. So like I mentioned, we participate with the National Kidney Registry or NKR and also UNOS, the United Network for Organ Sharing. So it's a pretty cool option if you're not blood or tissue type compatible, that there's still options out there. So that was the living donor world. We're going to talk a little bit about the deceased donor transplants. So the deceased donor, they are an individual who has gone through some tragic event in their life and their family or loved ones have decided to proceed with organ donation. There are organs, the organs are given a value based on the following information, such as the donor's age, they have a history of hypertension, what their creatinine is, what their kidneys looking like, their height, their weight, what caused the death, was it a stroke, do they have some vascular concerns we need to know about, do they have diabetes, and also their race and ethnicity. So we're going to talk a little bit more about a couple different options with deceased donors in just a moment. So that value that we just talked about based on those different factors of the donor is assigned a percentage, or what we call a Kidney Donor Profile Index, KDPI. So this gives us a little snapshot of what the quality of the donated kidney is. This chart in front of you, it's what we're looking at, the half-life of a transplanted kidney. So for a living donor, this is our best option. We're looking at 12.5 years of the half-life of that kidney. So that's why we say this is the best option if we're able to proceed with that. But we also know that's not an option for everyone, and some people do depend on a deceased donor for a kidney. So then we're going to look at a KDPI, or that Kidney Donor Profile Index, of 0 to 20%. This is the best deceased donor. Not far behind, we're looking about 11.5 years half-life. The next category, a KDPI of 21 to 85%, still good kidney. It's better than being on dialysis. We're looking at about 9 years. And then KDPI greater than 85% is still good. We're not going to get as much life out of that kidney, but we're going to get more than what we would if we did not have one, had to stay on dialysis. We're looking about 5.6 years. So we'll take a little look at that as a car to make it a little bit easier to compare. So that 0 to 20%, that brand new car that can parallel park and has all the bells and whistles and anything you can imagine, that's that better deceased donor kidney. So these are usually allocated to patients with the longest expected post-transplant survival. So these kidneys are the best kidneys. We want to make sure we get the most life out of them. The next category of 21 to 35%, still a great car, still has bells and whistles, doesn't parallel park itself or drive itself. These are allocated to pediatric patients first, and then according to the wait time on that waiting list. Then we got the 36 to 85% car. It still has automatic windows, maybe has a sunroof in there, but these are allocated according to wait time on that list. That's why it's important to get on there as soon as you can. And then that kidney, that greater than 85%, it's still that old reliable, that good car. These are allocated to those that are willing to accept a kidney offer from middle-aged donors with some kind of known prior health issues. This is a separate consent that we will have you review if you're interested. So that not quite ideal kidney, but that old reliable, that KDPI of greater than 85%, it is a separate wait list for recipients who sign a consent to consider offers. It does not mean that you have to take it. It just means you're willing to consider these offers if they do pop up. The kidney survival rate is typically lower than with younger, healthier donors, but please keep in mind if you're over the age of 40, your survival rate is better than what it would be on dialysis if you accept one of these kidneys. Donation after cardiac death, or what DCD. So again, these are a person who has gone through a tragic event in their life. They're not expected to live, and their family or loved ones have decided to donate their organs. So with donation after cardiac death, these individuals, these donors, fail to meet the criteria for brain death. That's a different route. So this one we're talking about is cardiac death. What they do is they take them to the OR. These donors are on life support, they're on a ventilator, they're on medications to help. So they go to the OR and they will stop that life-saving measures. And if their heart stops beating within a certain time frame, then they are declared deceased or dead. So they were removed from that life support before kidneys are removed to see if they meet the criteria for cardiac death. So there is with that, keep in mind there is a 40% chance of delayed graft function, that sleepy kidney, but the kidneys will recover. You just may need a little bit of dialysis for a short period of time post-transplant. Directed donation options. So this is why we stress the importance of getting the word out there. I know it's hard sometimes and you want to keep your information private, but there's a lot of good people out there that want to help others. So directed donation, if someone was to die in a hospital under certain conditions and their family or loved ones are aware that you are on a kidney transplant list waiting for a kidney, they can ask that their loved one's kidneys be directly donated to you. Of course, we have to make sure that the donor and yourself are blood and tissue type compatible, but these kidneys can come from anywhere in the United States. Now, this does not happen often, but we have seen it happen, so it's important to share your story because you never know who may be willing to step up when that situation, if it was to arise. All right, donors with risk criteria. So we do a lot of testing. We try to find everything we can, but sometimes there are some risk criteria that we like to talk about and make sure you're aware. So every donor is tested for HIV and hepatitis before you are even called with the organ offer. We want that information to be known so we can make the best decision for our recipients. If a donor has hepatitis B, some candidates can be safely transplanted based on on hepatitis B vaccination status and your antibody levels. So this will be determined by your transplant team. Hepatitis C positive donors can be offered to candidates who are medically appropriate. This does require a special consent in order to be eligible for this type of donor. And if our providers think this is the possible option for you, they will talk to you more individually and give you more information on that. HIV positive donors are not considered at this time for our candidates at our facility. And then any treatment for transmitted infections post-transplant will be offered to our recipients when medically indicated. So there are options if anything was to transmit post-transplant. A donor's risk criteria is based on the donor testing and history. So we must inform the intended recipients if the donor has any risk criteria. The donors are tested for HIV, hepatitis C, and hepatitis B within 96 hours prior to procurement, prior to them having those organs removed. An assessment of donors' behavior during the 30 days prior to organ procurement determines if there's a risk criteria for any HIV, hepatitis C, and hepatitis B infections. And those things we ask their loved ones or family about are any risky sexual behaviors, any IV drug use, were they in prison, did they travel outside the United States, any unknown medical or social history, and a child breastfed or born to an infected mother. We want all this information so we can make the best decision for our recipients. All candidates will be tested also for HIV, hepatitis C, and hepatitis B during the evaluation process. Hepatitis B vaccination status must be assessed and reported. So it's important if you don't have antibodies or it doesn't look like you're reactive against hepatitis B, we're going to have you get vaccination for that to make sure you're protected. And then transplant recipients will be tested on admission when they're called for a transplant, prior to transplant, and then 28 days and 56 days post-transplant. We want to make sure what we know at baseline before you go and get that kidney, and then if anything converts after the transplant. So donors with hepatitis C can safely donate to hepatitis C recipients. So the advantage to this, hepatitis C positive recipients typically get transplanted sooner because they have more options for a hepatitis C positive kidney. So there's more acceptable types of donor kidneys, which increases your chance of possible offers and transplants. Given the shorter waiting time, they can give medications that are called direct acting antivirals, or DAA, if they are to receive a hepatitis C positive kidney. And here at Christiana, we've been successfully transplanting these types of kidney scenarios for many years and have seen great success with them. So you may be thinking on the opposite end, can we safely transplant hepatitis C positive organs in the hepatitis C negative recipients? And the answer to that is yes. So there's a lot of research out there in the transplant world suggesting that it can be safely done. If the donor is hepatitis C positive and the recipient receiving the kidney is not, we can elicit the use of those direct acting antivirals to make this a safe option. So what this does, it increases the donor pool with organs enriched from younger donors, because we typically tend to see that in the donor world. There's increasing transplant access for some patients that are on the waiting list. You're making a positive situation or a positive outcome out of a terrible situation for a drug overdose donor's family. And it's cost-effective care. Those direct acting antivirals are very cost-effective. It is not for everyone, so there is a criteria involved in order to be included in potentially receiving hepatitis C positive kidneys if you're hepatitis C negative. We're going to take a look at your serology, the lab work that we take a look at, make sure you're negative for HIV, make sure there's no hepatitis B concerns or quantiferon gold concerns that pop up. You must not have an acceptable living kidney donor. So if you do have a living kidney donor, that's going to be the best option regardless. So we would have you proceed with that. We'll have you do if you have any pre-transplant infectious disease or hepatology concerns, we're going to have you consult with them, especially if you have any abnormal liver function. We'll take a look at those labs. We'll have you meet with infectious disease or hepatologist. It is a separate consent, so it's informed consent. We give you all the information we have to make sure that you can make the best decision if this is the right thing for you. No active illicit substance abuse, that includes alcohol and marijuana. You have to be less than 70 years old, and for women of childbearing age, contraception counseling is provided. So how are organs offered? So this is a 24/7, 365 process that's managed by our OPO and UNOS. So the OPO, or Gift of Life for Us, notifies UNOS of an offer. So with each offer, they generate a new list, and then our surgeon, if it is offered to us, will review the donor information to make sure this is something that's appropriate for our recipients or not. And then patients are notified by the transplant coordinator. If it's gone through all those channels and everything's panned out and everything looks good, we will notify the recipients. So when that kidney does become available, we have about 1 hour to reach you by phone. So it's important that you keep your contact information up to date. Make sure your emergency contacts are up to date as well. If anything changes with that, keep your phone on, especially when you're on the wait list and you're active. You want to keep your phone on, keep it charged, keep a charger with you. Don't put it on vibrate, 'cause sometimes you don't hear that when you're sleeping, because you never know when you may receive a kidney offer. So when you answer the phone, that ensures us that you are available, that you are in the area, that you didn't travel out to California or anything crazy like that. We're going to ask you some general healthcare questions to make sure you're healthy enough right now, especially with COVID and flu season. We want to make sure that there's nothing impacting your health that would make you not safe for surgery at this time. We're going to discuss the offer with you. We're going to let you know any of that risk criteria that you may need to know about. We're going to tell you about that KDPI percentage of the kidney. We're going to give you everything we can to help you make the best decision for you at that time. And then you decide, yes, this kidney sounds great, let's do it, I feel great, or no, I just don't feel this is the right time. So you decide once we get to that point if this is what you want to do or not. I've heard firsthand from many recipients on the wait list that it can be a very frustrating process, because you may receive many offers before you're actually transplanted. So you may get many of calls from us transplant coordinators all times of the day, and it may not pan out. The person in front of you may have received it, or something happened that we did not receive that kidney. So it can be very frustrating, but you got to hang in there. So sometimes we say the more calls we get, the closer and closer we're getting. So there are many recipients offered each organ. So if we tell you you're primary, that means you're first on the list for the kidney. If we say backup, that means you're not the first person in line. We'd like to have a backup person because things can happen. So you will be at a different place in line for each kidney offer. And ultimately, we have to do a cross match to make sure that it's blood and tissue type compatible, because we can't give you a kidney that's not compatible or appropriate for you. There is no such thing as top of the list, so the order of the list changes with each organ offer based on the following information: donor's blood type, cross-match results, the recipient's time on the list, recipient's state of health at that time, and that KDPI percentage of the donor. So all these things are taken in consideration with each offer. So UNOS makes the ultimate decision for who is allocated or who gets that organ. We want to make sure it's fair and equitable, so that's why this body's involved in the process. So we've talked a lot about cross-match tests, so we're going to talk a little bit more in depth about that. So cross-match tests tell us if the recipient and the donor are compatible. So a negative cross-match is what we want. We want there to be a negative cross-match. That means we can accept this kidney. A positive cross-match means that you cannot accept the kidney from that donor specifically. Antibodies do develop. They can develop from various things. So we do require repeat cross-match testing prior to transplant and during the evaluation and wait list, because those antibodies are fighter cells that we don't want to attack your cells. So it's important that we know what the antibodies are when we do the cross-match test. Panel reactive antibodies, or PRA. You may hear us talk about that while you're on the wait list, of a percentage of what your PRA value is. So the recipient's blood is tested against a panel of cells from many other people. This value can change based if you have received blood transfusions, if you've had any prior transplants, and for women, if you've had abortions or pregnancy, this can impact the PRA, the value. The higher this number is, it can make finding a donor more difficult, and it can impact the kidney survival. So while you're on the waiting list, it's very, very important that you continue to complete these monthly blood samples. So once you're listed, a tube of blood will be sent each month to our tissue typing lab, which is located at Thomas Jefferson Hospital. So what this does, it checks for the presence of new antibodies, and it's also used for testing against any potential donors that may pop up when available. If you're on dialysis, we have them ask them to draw this each month during one of your dialysis sessions. We like to keep it around the same time monthly. If you're not on dialysis, we have you go to one of our ChristianaCare labs to have this done each month, just because of the sensitive nature of where it has to go. It can only go to one specific place. Keep this in mind. It's important to keep up with this, because if we get a kidney offer in the middle of the night and I give you a call and you have not had this done in 2 months, you're going to have to come up to our ChristianaCare Newark ED, our emergency room here in Newark at the main campus, and have that drawn, just because we'll have to, it's a special process that will have to be involved to get it up to the right place. So that can be an inconvenience, and yes, hopefully we're getting a kidney, but it's very, very important just to keep up with it monthly to avoid that having to do that in the middle of the night. So here's some cool pictures. The surgeon may talk a little bit more about this when they meet with you, but this picture of the abdomen here, chest and abdomen, on the right hand side, typically they're on the right hand side. That's where the incision's made for your new kidney, so it goes in the front. You may know your kidneys you have now are kind of in the back, in your flank. When you get a transplant, when you get a new kidney, they make an incision here on the right side of your abdomen, typically. Some people do have the left, and that's where that new kidney is transplanted. So we talked about this being a blood vessel surgery. This is why. So this red vessel is your artery. This blue one is your vein. The new kidney that you get, we got to connect the arteries and veins from that new kidney to your arteries and veins to make it functional. And then we also have the ureter, or the tube that goes to your bladder where the pee goes. We have to connect that as well. So we need these blood vessels to be good, or it will not be a successful surgery. Another cool tidbit, you get that new kidney in the front. We do not remove the old kidneys. They stay in there. So we do nothing with them. So if you have those two in the back, they're just going to hang out there, and your new kidney is going to hang out in the front. So again, here's the renal artery from the new kidney going to your artery, the renal vein, and then that ureter that attaches to your bladder. So kind of some cool pictures to kind of put it in perspective of what's involved with the transplant surgery itself. As with every surgery you may have ever had or have to have, there are some potential issues or risks that we'd like you to be aware of. Those include bleeding, infection, a fluid collection in the wound, a non-functioning kidney, clotting issues, and urinary leakage or blockage. So most complications can be corrected and happen very infrequently, but we like to make sure you're aware that with kidney transplant, these are specific potential issues or risks that may pop up. So we made it to the kidney transplant, post-transplant phase. That's exciting. A lot more information to be involved with that. So what happens post-transplant? So for the hospital length of stay, if it was a living donor kidney, you'll be in the hospital for about 3 to 5 days. If it was a deceased donor kidney, it's usually about 4 to 6 days, because sometimes we see that delayed graft function or sleepy kidney that requires a little bit of dialysis for a couple days post-transplant. So that's why you see a little difference in that. We do not usually see that in living donors, because we're taking that kidney from the living donor and placing it right in the recipient in a relative short amount of time. Those anti-rejection medications, or those immunosuppressive medications, are started immediately. We want your body to accept this new kidney and not attack it. So you'll be on 2 to 3 medications for the life of that kidney. This, like I said, keeps your body from attacking the new kidney. Some of the side effects typically include nausea, vomiting, and diarrhea. It's important, if you already have concerns, some GI upset or any concerns with nausea, vomiting, and diarrhea baseline, that you see a GI provider and kind of get a game plan on that, because these medications can induce these kinds of side effects. Increased chance of infections and cancers can pop up post-transplant, especially with these medications. So that's why it's important, if you have any issues now, that we take care of them and get those treated appropriately, because post-transplant we want to avoid that at all costs. Keep in mind, any missed doses of medications can increase the chance of rejection, so it's very important you take these as prescribed by the providers. You want to take them. It could be a lot of medications, but they're very, very important to keeping you safe and keeping that kidney working. Like we mentioned, we're going to test for HIV, hepatitis B, and hepatitis C within 28 days and 56 days post-transplant. And then you'll have regularly scheduled follow-up exams and lab work with us to keep an eye on that new kidney to make sure everything's proceeding as it should be. For some of the follow-up, it takes place in our transplant clinic here in Medical Arts Pavilion 2 at our Newark ChristianaCare campus. Short term, like immediately post-transplant, you'll be here anywhere from 2 to 3 times a week to make sure we're adjusting the medications, we're getting the lab work, and we got you on the right track for what you need to keep that kidney going. And then as time progresses, there'll be more long-term visits all the way up to annually, just to make sure everything's still proceeding as planned. If it's important or applicable to your situation, we can assist with thanking the donor family. And then you'll have continued care from our transplant team for the life of that kidney. So it's important that you stay in contact with us and your team even if you move, so that way we can make sure we transition that care appropriately and keep you healthy and getting the most use out of that kidney that you work so hard for. A lot of people get excited, especially post-transplant, that they want to travel and see the world, and a lot of things that they couldn't do when they were on dialysis, but there's some things we want you to keep in mind. We ask that you inform us of any travel plans before you book your trip. It's always a good idea to purchase that travel insurance just in case anything was to arise. You cannot travel for more than 2 hours from home for the first 6 months after you receive your new kidney, after that transplant. We need you close by in case anything is to pop up. There's a high risk of rejection within those first 6 months, so we got to make sure we're keeping a close eye on everything. And then we ask that you do not travel outside the United States for the first 12 months post-transplant. If you live outside the United States, or there's a reason that you have to travel outside, our team will work with you to determine when it's safe for you to return. The medications can be pretty intimidating because there are a lot of them, but we promise they're all serving a purpose to keep you safe and healthy and make that kidney do its job. So there can be up to 10 different medications, and that can equal 20 to 30 pills a day. Some of the common medications, we have Prograf and Cellcept, and then there's an IV, a monthly IV infusion called Nulojix. So some of these medications that you're taking are to prevent or preventative to help avoid infections. We have some antibiotics, antivirals, and antifungals. Since we've wiped out your immune system with the medications to prevent your body from attacking the new kidney, we have to support it, and we do that with medications to help ward off any viruses or bacteria that may pop up. You'll continue medications for blood pressure, cholesterol, and diabetes unless it's not needed for any particular reason. And then if you're anemic, if there's still anemia, you may still need those EPO shots post-transplant. Some potential medical problems that can arise in the post-transplant phase include cancer. With skin particularly, we see a 50% chance at 5 years post-transplant, 80% chance at 10 years. It's very, very important that you see a dermatologist even now, just to get a baseline assessment so we know what your skin looks like before kidney transplant, and that way we know if there's any changes post-transplant due to this high risk. If there's any concerns now, we're going to ask during the evaluation phase that you see a dermatologist and get clearance if there's any concerns on your exam. Kidney cancers from your old ones, it is always a risk because they do stay in there. We do not remove those. And then there's a blood cancer that post-transplant, that there's a 1% risk. This is caused by the Epstein-Barr virus or monovirus. But again, it's a 1% risk that we see with that blood cancer. Delayed graft function or sleepy kidney. Again, sometimes depending on how long that deceased donor kidney had to stay on ice to get to you, can impact this. But what we treat that with is a little bit of dialysis for a short period of time post-transplant. And then keep in mind, rejection does not always mean you're going to lose that kidney. There will be a biopsy at 3 months and 1 year and frequent lab work. So this can be silent, this rejection. So it's important that you take your medications as prescribed, take them on time, and do the blood work that's needed to make sure we have you on the right regimen. All right, a lot of information that was thrown at you. You're going to also get more information that you can look at. There's a lot of stuff on our website, so ChristianaCare.org/kidney transplant. So a lot of good stuff on there. There's living donor information if you have anyone interested. Anything you can think of, we can get you information on. We are on social media, so if you are a social media fan and you're on Facebook, Instagram, we have information on there. We have a monthly newsletter to keep you connected from our kidney transplant program. So lots of ways that we communicate with you. We have a monthly living donor seminar that we do ask our recipients to attend at some point during their evaluation. There's a lot of good information on getting your word out there on social media to kind of potentially elicit some living donor interest. So we're happy to help you with that if that's something that's important to you or something that you want to know more about. So hopefully gained some knowledge out of all our our session here that we just spent going over. Hopefully, if you have any questions, just jot those down and we'll be sure to answer them at a later time. I appreciate your time and attention, and I look forward to learning more about you and seeing you in our clinic soon. Take care.